COPD and bronchial asthma. Okay?
लास्ट टाइम जब इसकी वीडियो बनाई है इसकी पता क्या है मैं सोच रहा हूँ सारा पूछ अच्छा मैंने डाला तो दिया लेकिन अभी वो प्राइवेट उसको पब्लिक नहीं ऐसे कोई बात नहीं
Okay, now silent. Didn't talk. If you want to say something, put your hands raised up. So I open my navigation for this lecture, so don't if I can forget something. Who know what is COPD? How it's abbreviation? What does it mean?
Chronic obstructive pulmonary disease.
Okay, it's very good. Так, воду. Астма. Okay, start. It will be not like a big lecture, it will be discussion. So, COPD, chronic obstructive pulmonary diseases, and bronchial asthma. It's both diseases. What's the reason is obstruction. Both diseases. In both diseases, the bronchus is closing. But the main different thing that in bronchial asthma we can 100% reversible obstruction. So we can open the bronchus again and start to work, and then bronchus will work okay. In COPD, if bronchus start to be obstructed, our treatment didn't give more obstruction but not opening. Okay?
In COPD?
In COPD. So, it's both obstruction, but asthma is reversible obstruction. Okay? So, next, main points. First, it's a obstructive disease. Both. Second main point, non-reversible. Non-reversible. Asthma?
Reversible.
So both
for first point, obstructive disease.
obstructive diseases, both non-reversible, reversible. Next, important thing, both these diseases in abbreviation is chronic inflammatory diseases. Okay? both these diseases is chronic. Now, another important point. Listen me very careful. COPD, it's diseases when it's coming after years. You can receive it. So you receive them if you're smoking. That's another part of the lecture. So the COPD, you will never burn with COPD. If you're a small child, in 10-year-old guy, or man or woman, never can be the COPD. Asthma can be in any age. It's starting from 1-year-old until 100-year-old patient. Okay? Because COPD producing due to factors, another exact factors. But asthma is a genetic disease. It's coming from your parents by gene. But very important thing that this gene, for example, from here, maybe 20 of you or 10 of you have gene of asthma. But in someone's the gene is sleeping, and someday, with some reasons, with some factors, this gene can be awakened, and you will start diseases in any age. Maybe after when you will be at 85, the asthma can produce the symptoms. And sometimes the patient says, I never have before asthma. And then we start again explain them that asthma can give the symptoms in any age. Before she was asleep, but now he's awakening due to some reasons. Okay? So, risk factors for bronchial asthma.
Smoking.
Smoker.
Smoking.
Genetic smoking.
Don't smoke.
So, reasons for bronchial asthma, it's a genetic.
Smoking.
If you have gene, so smoking, of course, and asthma, very low allergic things.
Allergic reaction.
Yes. So it's a dust. It's a pollution.
Pollens. Perfumes.
It's a perfume. No, and complicated chemical examining. So perfume, washing when you're washing. Pollen. So this any allergens. Risk factors for COPD. First place is taking what?
Smoking.
Smoking. Then also pollution. And third, it's sometimes. So usually 90% of COPD it's due to exogenic smoke. Smoke of cigarette, smoke of air pollution, smoke of any smoke. But sometimes everybody of us we have a antitrypsin special gel inside the lungs. And name is 1 antitrypsin. And this gel every time is on side of the bronchus, and some patients have genetically deficit, low range of this gel. And then this guy can produce COPD without these factors. Without these factors. It's a alpha-1 antitrypsin. So if we have a low range of alpha-1 antitrypsin, we also in the risk factors that we will have COPD.
Yes.
Okay? Because this alpha-1 antitrypsin not produce the special chemical things that is protect the lungs, and then you can produce, it's a produce chronic inflammatory thing inside the lungs. Okay?
Yes.
You understand? So, but COPD, it's every time smoking, pollution, and alpha-1 antitrypsin. For bronchial asthma, it's a genetic, smoking, dust, pollution, and complicated chemical things. So a lot of chemical insight. Force. Now, etiology. we don't have a etiological factor for both because it's both didn't produce by infection, didn't produce by so it's a common diseases. Here it's a no etiology because it can be genetic diseases, and this genetic can await by smoking, dust, pollution, or chemical things. COPD coming due to smoking, pollution, and antitrypsin. So now, like etiology is not exactly etiological factor, for example, as pneumonia, bronchitis, is infection. Okay? Yes? Not yours?
No.
So that's why we're starting by clinical picture.
Wait, I will see the navigation. It's okay.
Why I tell that its diseases must be both, because the symptoms very like to each other. In both diseases, you will have dyspnea. Dyspnea with wheezings. Both diseases will have wheezings, dyspnea with wheezings. Patient will have, you will heard it without stethoscope. It's a very extreme wheezings. Okay? But some difference in COPD, dyspnea can be age more than 35, as usual. Because to receive the COPD due to smoking, you need to smoke as minimum as 10 years. 7-10 years. Here, age start from
One year?
1 year old. From small baby.
Because it's genetic.
Genetics.
It can be in any age. Okay? If you heard, for example, dyspnea with very big wheezings, for example, in 25, it's just 1 or 5% that is COPD. And also this COPD will be due to alpha-1 antitrypsin. And 95% is asthma. So that's why I told you that it's both. Dyspnea with wheezings in both, but the difference is that it can be in any age. It can be usually more than 35. But also it can be younger, but if it's just have alpha-1 antitrypsin. Okay?
Yes, sir.
Now, cough. Both. Both diseases will have a cough, and both diseases will have a different type of cough. In COPD, usually, more often, cough with sputum. Usually it's a cough every time in COPD, but here sputum will be white, sometimes yellow, sometimes green, 3 colors of sputum. In asthma, more than 50% cough is dry cough. And in period of exacerbation, also sputum. Okay? Both diseases have cough, and both diseases can have and dry cough and cough with sputum. That's why differential diagnosis by cough is very difficult. Next symptom, what do you think?
Fever.
Fever, okay. But here, fever can be in both. When you have COPD, it's a chronic disease. And per year you will have 3-4 times exacerbation where you receive some viral infection, bacterial infection, and you will have fever. And also here, you will have a fever. Okay, what more? Thinking?
Weakness.
Weakness. And here also. But weakness here, it's a if it's COPD already, you know, we will talk about later. We have a 4 stage of COPD. If it's first, second stage, weakness rare, but third and fourth stage, weakness every time. Here, weakness will be just in exacerbation period, and another time, it's okay. Так.
Так, фактор развития, наследственность, профессиональные факторы, союз факторы, тренеры.
क्लियर हो जाती है ठीक है ना फिट्स ऑफ कप्स इसमें नहीं होते हैं वो सीओपीडी में होते हैं उसमें अस्थमा नहीं है अस्थमा में सांस बंद हो जाती है सीओपीडी में अभी आए सिस्टम में है ही शॉर्टनेस ऑफ ब्रीथिंग सीओपीडी जो है ना वो फिट्स ऑफ कप्स में
Okay, so about symptoms. Oh, Sarah, about symptoms we finish all. And very important thing that like also symptom, it's reducing quality of life. In COPD, patient because of progressive of diseases, if these diseases is starting, it every time will be going to progress. And it's losing quality of life because the patient will have every time dyspnea, what is increasing by time, and then it will be hard to him to go a little bit. After 10 meters he will already have dyspnea, and this dyspnea not reversible, and his quality of life very low here, but here we can again give for him quality of life. Okay?
Sir, in COPD, if rather than 35 age, if we diagnose him, and after 55 age he dies, because
No. If you have COPD in 35, if you recognize that, or 45, if you start treatment here immediately, the stage will be same.
so because airways are narrow, because they are not reversible.
Yes. So if
Then
you
after a few
no, if you will found, no, we will discuss it about diagnostic. Just listen, and we will come for him. Now clinical picture. Now clinical picture. When you will see the patients with bronchial asthma or COPD, first of all, when they will come to the door, you will see the dyspnea. And dyspnea will be, dyspnea will be in both diseases, and COPD and asthma. Dyspnea will be with wheezings, very hard wheezings, but in COPD it depends on the stage of the diseases. Because in the first and second stage, usually they have no wheezings, and they didn't know about diseases. And we found it due to another additional hiccup to, for example, with bronchitis, and additionally we found it COPD. So the first symptom, the first one you will see is dyspnea. Then in examination of the patient, so you need to go there because it will be in there. So the lymph nodes usually is normal. The lymph nodes is usually normal, and in COPD and in asthma, because the infection just if you have they have additional infection, if you will treat first of all additional infection, then the main diseases. In percussion or if you're doing downless of the lungs in both COPD and asthma, you will can just found that he have emphysema. So just increasing size of the lungs. By percussion, you will find nothing usually there. And in COPD, in asthma, the percussion, it's also just showing that it's a little bit hard inside. And then very important thing, that's auscultation. In auscultation, you will find a lot of wheezing in both sides in the lungs. Every time, both sides. It can be in one side. Both sides wheezing, from starting from up until down. Okay?
Yes.
Hard sound and wheezings. Then we have two types in asthma, just wheezings. And then he will say that he is sweating when they have a dyspnea. And also the dyspnea attacks. If patients say that at night time, exactly in the night, you have a more dyspnea. If it compared with the daytime, it's more talking you for asthma. Because asthma attacks, it's a night attacks, usually. More than 50% asthma attacks, it's per night. The coughing, dyspnea, all symptoms, manifestation is increasing in the night time, in asthma. In COPD, it's the opposite. Daytime, because due to activity. If patients with COPD have no active movements, the dyspnea will be less. For asthma, doesn't matter. And it's increasing at night when he is sleeping. Why it's increasing at night? Because the daytime we have a protection system and vegetative nerval system. Per night we have a parasympathetic system, and parasympathetic system give more attention for small things. If, for example, let's say 100 dust pieces will not produce asthma attack in the daytime, but when he's sleeping, this one same dose will produce the attack because it's a parasympathetic system. Okay?
Yes, sir.
Next, let's say, in lungs it's wheezings, cough. In COPD, cough with the sputum, and in asthma, usually cough is a dry cough. And about diagnosis. The symptoms and usually examination is same, but the different that in COPD, if it's already big stage, he will have a very skinny because he will very sick.
Yes.
In asthma, it's the asthma is not touching the weight, and in COPD usually weight loss. Okay. Now diagnostic in COPD. The gold standard
Gold standard.
gold standard is spirometry.
Spirometry.
Spirometry or lung function.
So the gold standard?
Gold standard? No, like a gold standard, it's a main thing with what you will diagnose this.
Standard treatment.
Yes, standard diagnostic for both. For both. What is spirometry? Spirometry, it's a small device. Now it's a small device. Before it was big devices. Now it's with time it's a small device. Now it's a both for asthma and for COPD. It's spirometry. What's the doing spirometry? It's a device. When you're doing very deeply breathe in, you put the mouthpieces, this device, and you blow with your force. What's doing this device?
Lung function.
The spirometry will give you correct information about lung volume. As you know, the lung volume calculated by liters.
Yes, sir.
Liters, okay? And it's forced vital capacity. So you need to read about one more. I will give you short information And about this, you need to read that poem. Forced vital capacity. It's mean how many. No, I will talk you easy way about understanding. It's mean how much air can go in to the lungs. And for vital, so we have a normal vital capacity. How you will know that is normal? How you will know that is not normal? It's H divided by A. So depending of your height and depending to your age in the world, our world, we have normatives. For example, if my age is 35 and I have 175 centimeters, my force vital capacity nearly to 4 liters.
4 liters.
Okay, it's depending on age and this, but you can calculate it by calculator. It's already inside the base of the spirometry. Any spirometer have this formula. So if you just put to the spirometer data about your age and height, he will automatically give you the normal. It's a first main thing. Next, it's a phi1. It's a force expiratory volume in 1 second. And then, third thing what we need, it's a phi VC divided to
FPV.
FV1. Wait, P1. So now, if we have volume, and then, so carefully, PVC, it's a volume. So inside, for example, 4 liters. Okay, it's a PVC. And Phi1, it's showing us, do you have obstruction or no? Because the device detects how many liters you in exhalation in 1 second, for 1 second. So, for example, if inside me, when I'm doing blow in, coming 4 liters, it must, as minimum, 3.2 go out in 1 second. As minimum, okay? So when you're doing inside, it's 4 liters is coming, and then for 1 second, you need as minimum take out 3.2 liters. It will be normal. If you have obstruction, so the low part of the bronchus, in 1 second, the flow will be more less. Okay, and then, for example, PVC, it's usually showing like this in the data. So let's see.
घर नहीं जाना वीनू घर नहीं जाना
So usually when you will have report about spirometry, for example, first of all you will have it in liters, and then exactly he will give you percent. For example, this is what I do it, and it's 100% for normal. For example, my normal is 4 liters, and I do this 4 liters, 100%. 3.2, it's a 90% of normal, and here will be 0.75. So because this one in Russian literature is index Tifno, just in the European speaking countries tell about this. This is the index Tifno. It's PVC divided to Phi1. If first of all, when you will see the result from the spirometry, first of all, you're looking here. Okay? If this numbers more than 0.7, you have no obstruction. And you have no COPD. first what you looking here. Then second you looking here. And just third thing, what you looking is here. So first, second, third. Okay? Now, it's a normal. If you will have COPD, it means that your vital capacity 4, for example, when I'm doing inside, I have in 4 liters, then Phi1 will be, for example, 1.9 liter. And here will be 50. And here will be 6%. So, if you see the result here, first of all, we're looking here, it's showing 0.5. It means you have obstruction. The bronchus is closing. Then second, you're looking here. If it's not 100%, it means that I'm not going in total. And then you're looking here, 60%. It means that I have obstruction and I just blow out 60% of my normal range. 40% is still inside. And then you can say that is COPD gold 2. Okay? COPD have 4 gradations. First, second, third, fourth. First is a light COPD, moderate COPD, severe COPD, and very severe COPD. So here it's showing mild COPD because obstruction. Okay?
Yes, sir.
It's a spirometry. In asthma, what's the difference? When we're doing spirometry, if for example it doesn't matter what kind of results we receive, after spirometry, we're giving 2 puffs of salbutamol. Okay? 2 puffs of salbutamol for patient, and then we're doing again spirometry after 10 minutes. And after 10 minutes, you're doing again spirometry, and after what? It's what was 60 can do 80. It's asthma. If you see the difference in Phi1 in patient after salbutamol, difference more than 12% and more than 200 milliliters, you can think it's asthma.
So what you can give it?
Huh?
Salbutamol.
Salbutamol. It's treatment for asthma.
Yes.
Yes. No, you see the this aerosol. So you're doing spirometry, then you're giving salbutamol, and after salbutamol you're doing again spirometry and compare them. If in Phi1 where was first it's a liter, then it's percent. If here will be more than 200 milliliters, for example, he was now before was 1.9, and then it's now 2.1. It's increased for 200 milliliters, and here will be not 60, minimum 72, 12%. The bronchodilation test is positive, and it can be asthma. Because in COPD, it's a non-reversible obstruction, and if you will give salbutamol and do it again, spirometry for patients with COPD, these changes will be less than these changes. It can be 5% and just 100 milliliters. COPD don't increasing the size of the bronchus after salbutamol.
Yes.
Asthma will open. Okay? Everybody understand?
Yes.
So the gold standard of diagnostic for both diseases is spirometry. And spirometry we have 2 types. If we have COPD, the changes in spirometry will be minimal.
Yes.
If we have asthma, the change in spirometry will be more than 12%. And then you confirm that
It's bronchial asthma.
bronchial asthma. Why we need to do spirometry? Because the treatment of
It's
both
different.
diseases is different. But now, nobody will not tell you when you are students. I just, because of my practice. Now, how are we doing now? Then, these rules was already, I think, 35 years for these rules. But now, after new technologies, after new treatment, we have the challenges. Now we recognize, the pulmonologists recognize that sometimes if we will take 10 patients with asthma and doing spirometry and want to see this difference, just 7 patients from 10 will have this difference in asthma, and third of patients will have no difference, but it's still asthma. Why they can do? Why it can be not have positive things? If patient last 24 hours before took pills like antihistamine pills, like a suprastin, Tavigil, no, they're doing, oh, I have allergy, and put the drugs, anti-allergy drugs. If they 24 hours as minimum before have a pill, antihistamine pills for allergy, the test will be negative. So first, if patient with asthma already before 24 hours minimum before have some kind of puffs of some treatment, salbutamol and other things, this will be negative. So you need to remember that.
Yes.
And sometimes also we recognize that from 10 patients with COPD, 5 patients will have this also positive. Why? Because the COPD patients usually in our country don't have a treatment. So they didn't know that it's COPD. And then when you give the salbutamol, they have a so strong obstruction that it reacts to salbutamol and also open it. That's why when you're giving the if, for example, you have a spirometry, the patients with asthma, and then you have negative the test, but he's showing you that you have COPD. You give the treatment of COPD and ask him to do spirometry after 1 month. And if after 1 month his, for example, Phi1 was 60, and after 1 month from 60 is going to be 90, it's not COPD, it's asthma. So exactly confirmation of the diagnosis will be after 1 month. Okay?
Yes.
On the repeating spirometry after
1 month.
no, after spirometry. Okay, 10 minutes break, okay? And then we will continue.